Hello and welcome to the Complete Health Podcast, the podcast that brings you a complete view of healthcare, exercise as medicine, and much more.
We're your hosts, Helen O'Leary and Reece Noble, both physiotherapists at Complete Physio and Pilates in London.
Today marks the start of National Foot Week, so we felt a very fitting way to kick things off is by talking to someone who knows more about feet than most, foot and ankle specialist physiotherapist Jane Baker.
This episode is absolutely bursting at the seams with information as Jane goes in depth with us about what exactly a foot specialist physio is, the very long list of conditions that she treats, some simple mobilisation techniques we can all use to keep our feet mobile and healthy.
And just when you think this episode couldn't offer any more, Jane also outlines what she goes through during an assessment of a person's foot and ankle, and also links how disorders of the foot and ankle can affect and cause pain in many other parts of the body. Hello and welcome everyone to episode 18 of the Complete Health Podcast.
And then this is another one I'm super excited for. Not so excited for the fact we have to wear masks now, but we will live and learn. So our guest today is Jane Baker.
Hello.
Wonderful Jane Baker. Now, for those of you that don't know Jane, she works with us here at Complete Physio in Chelsea, and her specialisation is in feet.
That's right.
Indeed. So, feet are an amazing part of the body. They do amazing things for us. They're the start of a lot of our movement chains, and they affect everything up the chain. So I'm really looking forward to this, particularly because I'm having some foot issues at the moment, which I'm actually seeing Jane for.
I feel like the reason we spoke to Dan was because you needed some work in your triathlon.
I'm just using all of these for my own. So,
We're going to use you as a case study
yes, we are
a little bit
indeed.
later. I think that would be quite interesting.
So for those of you that haven't listened before, my name is Reece Noble. I am one of the physiotherapists here at Complete Physio, and I'm here, as always, with my delightful co-host, Helen O'Leary.
Delightful this week.
Delightful.
What were you last week?
I don't know.
Depends on what day you ask. And of course, we've got Jane. So Jane, thank you for being with us.
Well, thank you very much for inviting me.
Absolute
It's
pleasure.
been a joy working with everybody here. I'm here on a Monday.
Yep.
And the other days I'm in a podiatry clinic in Harley Street, working really closely with the podiatrist there, which
Fantastic.
is brilliant because we just pop into each other's rooms and ask each other to have a look at patients and cross-refer, so it works really well.
Amazing.
Yeah.
So, leading on from that, Jane,
Yeah.
what's your background? How did you get into physio? How did you end up as a foot specialist physiotherapist?
So, as much as I hate to admit it, I've been physio for about 33 years.
Wow.
I know. I graduated in...
Stuck at it.
I know. I graduated in 1988. 1988. I graduated in 88.
I won't tell you how old I was in 1988, Jane. I was alive.
So was I. It's okay.
Oh my god. I did 2 years work in the NHS, and then I actually moved to America and worked in private healthcare in the States for 11 years. And then when I came back to the UK, I decided that I wanted a bit of a break. So I just sidestepped into veterinary physio.
Oh,
wow.
So I trained as a veterinary physio and worked a split practice of human and animals for about 4 years.
Big animals, little animals.
Both dogs and horses.
Wow.
Wow.
Yeah, so I did that for a bit down in Hampshire for about 4 years. And then decided actually that I preferred working with people and should have just got a dog myself. And then came back and worked in London actually and did a lot of corporate work with all the big banks. And then worked with a clinic called Kensington Physio. And in that time, I started seeing a lot of patients with foot problems. And I don't know about you guys, but when I was at physio college, we worked basically from the brain down. And the last thing that we studied were the feet.
For the last week.
Pretty much the last week, at which point everybody had switched off. Nobody took any notice whatsoever. And they became essentially paddles at the end of the legs. And nobody really took any notice of them. So I started doing more and more work with people. They'd come in with hip issues or knee issues and then go, oh, actually my foot's hurting. Or I'd be looking at them walking and notice that their foot didn't move or their big toe didn't bend. And I started to get more and more interested in how the foot was affecting the rest of the body and vice versa. Did some courses and started treating people's feet. And I think the thing that prompted me the most was people would have been to see a doctor or their GP with plantar heel pain or arch pain or big toe pain or ball of foot pain, particularly the older population, and come back with, well, everyone gets foot pain.
Yeah.
We're just being told to live with it.
Yeah.
And it's such an important part of the body, and we use our feet every day. We have to use them to get around. And it just was quite upsetting that people were struggling with foot pain and it wasn't being treated. So I just took it upon myself, got in touch with foot and ankle consultants, went and watched surgeries, sat in on clinics. There's an amazing special interest group called the Association of Foot and Ankle Physios.
I did not know that.
Which is a great resource, for courses, but also to find a foot and ankle physio in the UK. So I've done lots of networking. If I've had a patient who's come from quite a long way away, found a local physio, which has been brilliant. And they've run cadaver courses, which have been fascinating.
Yeah,
when you look at anatomy books and you think that the Achilles tendon is this beautifully structured, fine detailed tendon and all the joints are perfect, then you actually open up a cadaver and you see the conglomeration of tissue that you're just like, oh my god, how on earth do you figure out how anything works? So I just started to get interested and started working with people and getting good results, and over time decided to just take foot and ankle referrals, and actually thought that it would completely annihilate my caseload.
Yeah.
I thought, oh my god, I'm not going to get any patients. And started to get referrals and see more and more feet and get better results, and it just piques the interest, and then you develop this passion for it, and now it's literally become a real passion of mine to educate people about feet, educate physios or personal trainers, sports therapists, but also patients themselves. And what is so interesting, I did a course years and years ago called When the Foot Hits the Ground, Everything Changes.
That's a nice name.
Yeah, and it's so true. But you know, if you get a foot that has a big toe joint that's painful or doesn't move, it's going to have an effect somewhere else.
Yeah.
Your hip's probably not going to extend because you can't roll through your foot properly. So you've got to, people say, oh, you're a foot specialist or foot and ankle specialist, and I have to reframe it and say, I listened to Annabelle's talk and she said, it's not just a shoulder.
Yeah.
You have to look at the whole body. And if your thoracic spine isn't rotating, it's going to have an impact lower down the kinetic chain. And vice versa, if your foot's not absorbing shock, somewhere else in the body is going to absorb shock.
Yeah.
So you may get a patient who comes in with back pain, but actually it started much lower down the chain.
Yeah.
So it's a really interesting focus, but you can't actually forget the rest of the body. Even when you're treating somebody who's post-op, so they've had a bunion surgery, you were always looking at, okay, what was the primary cause of the bunion? Because it's all very well having a corrective surgery, but if you don't look at the cause of the problem in the first place, is the patient potentially going to end up with problems that will repeat issues further down the line?
Yeah.
So you said there about people went to see their GPs and then would kind of come in and say, oh, I've just got to live with it. So do you have to live with foot pain?
Absolutely not. So there's always a pathway, isn't there, with any injury. So you try and live with it. If you can't live with it, then you're going to seek help, and hopefully at some point you get directed to a physio or a therapist who's going to have a look at what the problem is, assess, address, treat. If things aren't progressing, your next step is to go maybe for some kind of invasive procedure, steroid injection, hyaluronic acid injection. If that's not working, whatever the problem is, possibly a surgical intervention. But what, particularly when I work with Simon Costain, who's the podiatrist I work with, we always have the philosophy, it's probably most physios actually, that surgery is the last resort.
Yeah.
It's never a silver bullet. And as much as you think that it's going to take away pain, there's all the other issues and risks associated with surgery.
And that's for any part of the body.
Oh yeah, absolutely.
We're not vehicles, you know. No. You don't take out the carburetor and just sort of replace it. Like it's a knock on, and it's a system, isn't it?
Absolutely, and particularly with, well, I can't say particularly with feet. Actually, with most other parts of the body, if you've got pain, you've got dysfunction, you've got muscle weakness and atrophy, you've got other things going on in the body. If you can address those before you go into surgery, your outcomes are going to be so much better. It's the same with a shoulder surgery or a knee surgery. If you go into a knee surgery with a fixed flexion deformity, you're probably going to come out with an issue as well. So address it beforehand as much as you can. Take away the whole mystery of surgery with a patient. Particularly, my experience with feet is that patients who have painful feet hate their feet.
Yeah.
They don't want to look at them, they don't want to touch them, they really just have this sort of disassociation from their feet. Put that person through a surgery where they've now got an incision, bandages, dressings, bleeding, post-op pain. You've got another whole issue to address.
Yep.
So if you can demystify everything before they go into surgery, get them touching their feet in particular, just getting familiar with their feet again, their post-op experience is a lot less traumatic.
And what kind of things do you normally see kind of walking through your door?
Oh gosh. Walking through my door, no pun intended.
I didn't even clock on that. It's really been a long day.
Limping through my door. So, gosh, anything. So it could be. So what have I had today? I've had somebody who was 7 weeks post-op from a kylectomy, which was basically she had a very stiff big toe joint, and she went for surgery to clear out the extra bone around the joint.
Can they do that now?
Yeah, they still do that.
I would have thought they would stop.
Interesting.
No. That was a minimally invasive surgery, so her scar was literally about...
Sorry, I'm just opening
If
nuts for
you're
anyone listening.
hearing the crackling, it's Reece having a snack.
I can't open it. Oh, there we go.
And you're going to hear him chewing.
Yes.
No, my mask will mask that.
So she was 7 weeks post-op and just needed a little bit of help with swelling and exercises. She was still a little bit stiff. I saw one of Reece's patients who had been struggling with Achilles issues and then big toe joint pain with very rigid supinated feet. So he had very high arches with very stiff joints throughout the foot. So when the foot is supposed to be in pronation flexible, there was no movement in the foot, so he wasn't shock absorbing at all. And of course, as with lots of people and lots of our patients over lockdown, he'd increased his running. Yeah. So exactly the same with any injury, increased load, increased volume, problems start to come up. What else do I see? I see lots of people who come in with bunions trying to avoid surgery, which is great. I see people with metatarsalgia, which is a generic term for ball of foot pain, but there's lots of reasons for that. I see people with stiff big toes. I see people with hammer toes, with injuries, so they may have stubbed their toe. I did see a patient who dropped a 4 kilo metal weight on the end of her big toe, which wasn't pretty. I see people with plantar fasciitis, arch pain, heel pain. peroneal tendon, so lateral ankle pain, ankle sprains. What else? Oh, tibialis posterior. That's one of my favourite things. Issues with tibialis.
Why is that your favourite?
You don't hear that every day, do you?
I don't know. It's really satisfying to treat.
Right.
It's really hard to treat. If you get it early enough, you can have really good results. And I know you had mentioned about orthotics when we were talking about what should we talk about. And in combination with supportive insoles and strengthening, you can get some good results with tib post issues.
Yeah, the way to think about orthotics sometimes is as like you'd think about a brace for another part of the body, isn't it? Like a knee brace. So if you had a knee operation, you might wear a brace for a little while, but eventually you want to get off it. Is that a similar line of thinking to orthotics?
Yeah, so there's depending on the podiatrist that you talk to, but I think nowadays the role of an orthotic is to support a foot whilst it's being strengthened, with the ultimate goal that you may not need orthotics long term, but some people do. Some people will need to be in an orthotic long term. My goal is always, if a person is given a set of orthotics, I will always say to them, you need to review with your podiatrist maybe every 6 months. Particularly if you're doing strengthening work, because your foot, just like the back, if you're wearing a brace, a supportive brace, and then you're doing a strengthening program, you may not need to wear it all the time. You might need a less supportive brace, and then you can get rid of it. It's the same with insoles. You may need a really supportive insole, and then as the foot gets stronger, you can decrease the support of the insole.
I think that'll come as a big surprise to a lot of people, that you don't, once you have orthotics, that doesn't mean you have orthotics forever.
Yes.
Yeah.
That'll be surprising to a lot of people.
Yeah.
Because it's one, I find it's probably one of those set and forget areas. Like you see people with this horribly worn out orthotic, and you say,
they've had for 20 years.
How long have you been wearing that for? They say,
exactly.
6 years. And you're like, have you had it reviewed? No, I
Yeah.
haven't. So they don't seem to, and whether that's
Whether they don't get told,
education on the side of the podiatrist, or just an expectation, or probably they were in pain, put their orthotics in, no more pain.
Yeah.
I love these orthotics.
Yeah.
But,
There's two things with orthotics. That's one thing that I will always encourage people to do a review with their podiatrist once they've got orthotics. The other thing I would encourage patients to do is have an orthotic. So lots of patients I've seen, or maybe you guys see patients, and they come in and they go, oh, I've got 10 pairs of insoles, I hate them all. Because they were given a set of insoles and then went off and they weren't comfortable, and then they didn't go back to the podiatrist and review them.
Right.
And I'll usually say to a patient, if they've just been given a set of insoles, you might have to come back 3 or 4 times just to tweak them.
Well, it's like a pair of glasses, like that. Glasses, you'd go to an optician's, you'd get a check, you kind of walk home, you go, no, these are giving me headaches, so you go back again.
Exactly.
Same thing.
It's, you're absolutely right. And 6 months or a year into wearing those glasses and your eyes have changed slightly, you go back for a checkup, right? So do the same. It might be actually that your foot's got weaker. And you're starting to get pain, and it's not the orthotic, but it's actually that your muscles have got weak and it's not supporting the foot. So you need a review, or you need to see your physio or your Pilates instructor or your trainer and start doing foot exercises, which could lead us onto
really nice
feet
segue.
curls for the feet.
I was going to say it could lead us very nicely onto a very quick chat about footwear.
Yes. Oh, yeah.
Yeah, for sure.
So, this is always going to stir up a big debate.
As in, like, what type of footwear people should wear.
Yeah. So you've got the barefoot shoe brigade.
Yeah.
And there's a big push, which I don't disagree with, that if we spend all our time stuck in thick-soled, inflexible shoes, a bit like the knee brace, the back brace. The muscles are going to go, I don't need to do anything. I'll just stop working. So it is really important to look at your footwear, but also to spend time barefoot.
I love
So
barefoot.
walking around.
It's like my favourite thing.
Walking around the house barefoot, you've got 200,000 plus sensory nerve endings in your feet. It would be like putting your hands in mittens and walking around and having your life in a pair of mittens if you are constantly in footwear. And your feet you've got so many muscles, you've got 4 layers of intrinsic muscles in your feet. They're really muscly. And so if you start not using them as we should use them, they are going to atrophy, they're going to weaken, and they're not going to do the function that you want them to. Take a look at people who have to use their feet for function. So people who can't use their hands and they've learned to use their feet. There was a massage therapist in the 2012 Olympics, and she massaged with her feet.
Wow.
And she had the most incredible, dexterous, strong feet. And it just goes to show that you can retrain and you can strengthen and you can
adapt and change.
You can adapt and change.
Yes.
And that's what I'm trying to do with my patients, is get them improving their foot function when they've got things like a stiff big toe or hammer toes or arch pain because their intrinsic muscles are weak. We're just trying to restore function, just like the rest of the body.
So with footwear,
Yes.
trainers, ballet pumps, work shoes, high heels, no shoes.
So there's not a an always and a never for me. I love, even as I'm a foot physio, I love wearing high heels.
Jane is like one of the most stylish physios I think I've ever met. It's like Amanda Lau. Have you met Amanda Lau? She's a podiatrist. Amanda, if you're listening, I really hope you are. I always just used to be in awe of her when she came into clinic in these amazing dresses and high-heeled shoes and just used to assess people's feet.
Yeah.
I'm like...
I don't get that when I come into clinic in dresses and high heels though.
Nobody appreciates that, do they?
Very disappointing.
But so I will wear high heels. I'm very aware of the effect that they have on my feet, that I might be trying to squash my toes into a narrow toe box when a foot is designed to be actually wider at the toes. If you look at a baby's foot, someone said to me the other day, you never see a baby with bunions. Which is true.
Can you imagine if you did?
That would be really creepy.
But it's true.
Yeah.
A baby's foot is actually wider at where the toes are.
Yeah.
Whereas we've actually pushed our feet from childhood into narrower toe box. We've
all got our feet
out. We've all got our feet out. We walked into this room and immediately took our shoes and socks off when we knew it was Jane.
So ideally, you look at my feet, you can see I can spread my toes out.
We're going to go and get a close-up camera for you all.
Okay.
Let's get this camera.
Okay,
I can do
Just a second.
That's as far as I can get.
Yeah, see your little toes, which have their own muscles.
Just don't move.
Don't worry.
My left is significantly not as good as my right.
Yeah. Okay, so these are my feet. So this would be my toes in narrow toe box shoes. So I can actually give myself a bunion here on this side. And that would be what my foot would look like in a tight shoe. But I can correct that and I can spread my toes out. You look at my toes here. I can spread my toes out to correct for having spent time here. So if I do wear high heels, I will actually spend time either popping my fingers between my toes, which I can demonstrate in a minute, and spreading my toes out, massaging my feet, and strengthening. Now if we look at Helen's toes, if we look at her trying to spread her toes, got some function of her abductor here. Her little toe isn't doing a lot.
Is it doing anything? That one might be doing something.
A little bit.
I mean, that one's doing nothing.
Not a lot. And it would be interesting for her to spend time trying to put her fingers through her toes like this. So you basically shake hands with your foot and spread the toes.
Oh, that's really not very nice.
So you're really tight between your toes. But that again is something that will
Reece is
change
feeling
over
that.
time. Can you do it?
Can you get in?
Yeah.
Oh,
Let's see.
that's it.
Yeah, you can do it.
Oh.
And what a nice way to mobilise your foot.
Oh, I
Yeah.
could do this in the evening.
Yeah,
So
you
this
could.
would just be something that somebody can do in an evening after work, after being on their feet all day or sitting down all day in shoes.
Absolutely. So we're incorporating touch and sensory stimulation, which is really important. Now, lots of people who have foot issues won't even get anywhere near putting their fingers between their toes.
Due to, like, they just physically can't gap
They
it enough.
physically can't gap it enough.
Amazing.
So you never ever, this is really important, you never ever force that position.
Ah, so what about, I feel like we're segueing all over the place, but what about when people come into you, like, you know when you go for a pedicure,
Yeah.
you get those things that go between your toes and
Yeah.
then people walk around in them.
So if you have a foot like mine, that's something that I could do quite easily.
Mhm.
But if you have a foot that, even yours, you've probably struggled to put those pedicure toe separators in, or
Yeah.
there's another piece of kit called yoga toes.
Yeah.
They're quite thick, solid silicone.
Yes.
That's an aggressive stretch. Now it's something that you can build up to, but it's not something that I would recommend initially.
Okay.
So I wouldn't force anything in between the toes. These are really gentle, soft silicone toe separators,
We can put the links to those in the
Show notes, yeah.
in the show notes.
which go between the toes, and even putting these on and just sitting with them is a nice way of just encouraging that space between the toes, but not walking on them
Right.
initially.
There you go.
You can exercise with these on, but you just need to get used to that extra range of motion.
Jane, what percentage of people that you see with foot pain would have pain somewhere else as well? Like a knee or a hip or low back pain, do you think?
Gosh, that's an interesting question.
Question without notice.
I reckon that if you left foot pain long enough, most people would have pain somewhere else.
Yeah.
But it depends on how quickly they decide to sort the foot pain out, and whether they go, I've dealt with my foot pain, now I've got hip pain.
Yeah.
I'm going to get my hip pain sorted out, because they don't necessarily associate their foot pain as the cause of their hip pain.
Yes.
Do you think a lot of people see you after they've got everything else and almost as a bit of a last resort?
I think now, because I've been doing it for probably 10 plus years, I see most people who've just got foot pain.
Okay.
Because just from a referral basis, people know people who talk
Yeah.
about, oh, foot pain, oh, go and see Jane, she helped me with my foot pain. So sometimes I do get people who've got pain
Whereas I feel like
lots of places.
a lot of the time I send you clients isn't for a lot of our chronic back pain or post-surgical back clients that have got a lot of foot stuff going on,
Yeah,
that have never addressed that and have addressed their back pain.
yeah. So I tend not to get the primary referral as the other body areas.
Yeah.
I get the primary referral as the foot and ankle. So maybe I get mine a little bit earlier. And then I will get people like you or Reece, who are treating people for other stuff and treating their feet, and then just want a little bit of an extra set of eyes on the feet.
Yeah.
Like your guy today.
Yeah, absolutely.
He's an interesting case.
Yeah, and like it was good to get your eyes on it, because I sort of was in the right direction of what was going on, but just couldn't quite specify it with the concise nature that you did. So just chatting about it afterwards, I was kind of had a few like light bulb moments.
Yeah.
Of, oh yeah, of course. Yeah, that's what I.
Nice.
Yeah. So yeah, certainly really. I mean, I've sat in with you for a few now, and it's super interesting to see. So another area I want to look into more, Helen. I look at every podcast like I've got to do more of that. I've got to do more of that.
I want to teach you more of it as well.
Yeah, great. All right, I'll be in.
What should people expect when they come and see you?
So, as with any physio, I'll take a full history. When did issues start? What they're experiencing. I want to know what previous injuries they've had that may have affected their feet. So it might be, for example, that
they rolled their ankle 6 years ago.
It might be that they rolled their ankle 6 years ago and damaged their ligament on the inside of the ankle, and then started training for a marathon. And
He's looking very sheepish at the moment.
and their tibialis anterior tendon became an issue.
It's very angry tendon.
And again, as with how other physios treat, we could have just treated the tibialis tendon issue. But unless you're actually looking at why that's become inflamed or flared up, you're not going to settle the problem. And he had a very stiff foot, and actually the tibialis anterior was overworking, so mobilised the foot.
It was doing a good job for me, basically.
Yeah.
It was working hard.
So we'll always look at history. There might be a family history of bunions. That's just interesting to note, because then you're actually saying, well, what are your kids' feet like? Maybe we need to start addressing those sooner rather than later.
Interesting.
And then I will look at them walking. I'll do all kinds of different gaits with them. So I'm basically doing an overall screen to be able to pick up things to hone in on. So
it looks like the Ministry of Funny Walks.
It does look like
And we'll get
full
Reece to
Monty
video some of those later.
So for example, I'll look at them just walking. I'll look at them walking with their feet turned out. I'll look at them walking with their feet turned in. So I'm getting a global look at what their hip mobility is like, but I'm also looking at when they walk with their feet turned out, do they pronate on mid stance? Is their foot flexible? Is one side the same as the other? I'll get them to walk with their feet turned in. I'll get them to walk as if the ceiling's very low. That's a really good way of determining whether they've got early heel lift. If they've got early heel lift, that is telling me that I need to check their calf flexibility or their ankle mobility or their big toe mobility. So I'll do a general screen. I'll also screen their back, because I'm also looking at leg length. I'm looking at pelvic mobility, sacroiliac joint, stalk test, all that stuff. I'll check hip mobility. I'll do Thomas test, so I want to know if they're tight in their hip flexors, because if they can't hip extend, that's going to have an impact on how the body's working or how the foot's moving. I will look at proximal tib fib joint, because I want to know whether there's tibial rotation. I'll look at distal tib fib joint. I'll look at cilius and gastroc flexibility. I'll look at big toe joint mobility, plantar fascia flexibility. I'll look at balance. I'll look at single leg eyes open, single leg eyes closed. If they're really good, I'll be looking at dynamic balance with head turning.
Yeah, that's hard.
I'll look at and then I always say to the patient, I am going to look at your foot at some point. But I actually need to get a really clear overall picture of what's what's going on in the body. Then I'll look at a more, depending on what they've come in with, obviously, and how much pain they're in, because some of them might not be able to move to be able to see, for me to see that. I'll look at foot muscle strength, so peroneals, tib post, tibialis anterior, flexor hallucis longus, flexor digitorum longus, extensors, so the extrinsic muscles of the feet. I will look at the intrinsic muscles of the feet. So a bit like we did, can you abduct your big toes? Can you do lumbrical or intrinsic function? And what's the mobility like in the foot? And then I will check joint mobility in the foot. So for example, if a patient has limited ankle dorsiflexion, I'll check how the talus moves. Is there a restriction in the anterior posterior glide of the talus? I'll check all the midfoot joints, the navicular glide, does the cuboid move, the mid tarsal joints, the metatarsals, and do the sesamoids move if there's a sesamoid issue? It depends. That's a global overview of everything that I could look at. Sometimes I'll check everything, and sometimes I won't. It depends. But that's pretty much, I typically see patients for an hour at least for their first appointment. And
Surprised you fit it all in.
There's
a lot there.
Yeah. And then explain everything to the patient, what we've found, the logical reasoning behind their injury or their presentation or their pain or their foot type, and come up with a management plan.
There we go.
Wow.
There's a lot to it. So, we have to wrap up there.
Okay.
But that's a really interesting insight into, I think, the complexities of the foot. Like, there's lots of layers there, which is amazing.
No pun intended.
And there's a lot to look at, and it sort of, hopefully after listening to this, it becomes obvious how it can affect other parts of the body.
Yeah.
And things like that. I would really love for our next episode if we can go through how the foot functions in gait. You maybe look at how you test the muscles that you've just been through, and then we can do a bit of a case study on my foot, and we'll see what I'm not doing, and it becomes clearly obvious when we look at things. Sound reasonable? Perfect. Excellent. Well, thank you very much, everyone, for listening. We will be back very, very soon again with Jane, where we're going to have a look at the wonders of feet and then look at my not so wonderful foot. So we'll see you then.
That concludes episode 18 of the Complete Health Podcast, just one part of our 3-part chat with Jane. In episodes 19, Jane continues to share her abundant knowledge with us as we look into how the foot functions during gait. We take a close look at Reece's feet as a case study and handy tips for physios and other healthcare professionals out there on how to perform a basic assessment of the foot and ankle.
If you would like to get in contact with us or Jane, all contact details are in the show notes, and we have also popped in the link to the gel spreaders Jane talked about in this episode.
For another week, stay healthy and goodbye.